So today's speaker is one of the greats in the orthopedic world, and I know we're in the Neuroscience Institute here, but I really hope that the message that he carries beyond the technical detail will serve as an inspiration for all of you here. Dr. Louis Zirkle is an orthopedic surgeon. The Humanitarian of the Year award from our academy is one of the many awards he has won. And he is a name brand around the world with Sign Fracture Care. A little bit about his background. He's from Eastern Washington, from Richland, Washington, where he actually works and practices also. He went to Davidson College from 1958 to 1962. He worked at Duke University Medical Center 1962 to 1966. And did his residency in 1966 to 68. And then a life-changing event happened when he was drafted in the U.S. Army and sent to Vietnam from 68 to 69. This was a game-changing experience for him as he felt a strong duty and inspiration to help those in need that would basically govern the remainder of his professional life. He completed his orthopedic surgery training at the U.S. Army and Shriners Hospital in L.A., and he's been again in Richland, Washington from 1973 onwards. At some point in time, and he'll probably tell us about that a little bit, he conceived this idea of creating fracture care improvements around the world, realizing that fracture care is an overlooked entity from the vast majority of governments around the world, and that there's a tremendous amount of suffering from untreated or maltreated trauma and injuries around the world. Dr. Akshal Patel and I had the great pleasure and privilege to see what Sign has created recently at their annual meeting. We're invited to speak about the potential of improving spine care and brain trauma care. And it was just an amazing experience to be in this center with over 500 surgeons from truly around the world learning how to improve fracture care. We're very privileged to have Dr. Zirkle here as a visitor and a visiting professor to SNI. And Lou, why don't you come up and tell us a little bit about how to improve fracture care in the world?
Thank you. Thanks, Jan. Appreciate it. I'm very happy to be here, and I really thank you for the invitation. I thank Jens for, I've known him for years, and for his leadership in the many jobs that he has been in. And I think this is a wonderful possibility for collaboration. I'd like to tell you a little bit about where we stand and start off with a video which tells you a little bit about Sign in a video way.
To belong and be look around, these are the lives that the world has forgotten, waiting for doors of our hearts and our homes to open. Boys become kings, girls will be queens, wrapped in your majesty. When we love the least of them, then they will be brave and free, such a name in victory. We will love the least of these. 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 We will love the least of
That tells a lot of the story, and but I want to talk about how Sign began. It began with sentinel events and a lot of emotion. I think when you have things happen for you, with you, and have an emotional content to them, you remember them, and you're more likely to do something about them. The two emotions I had in Vietnam, or the major emotion, was inequality. In wartime, the civilians are the victims. They have no stake in the war usually, and it closes down. All the medical schools closed in Vietnam except for one that was run by the AMA, and it ultimately closed. So the people had no choice, and while we treated the military very well, the civilians didn't have a chance. This is another sentinel event. I came back and wanted to pay back, so I went to Indonesia. And in Indonesia, they had one orthopedic surgeon for 57 million, and at the end of 10 years, I went over there for a month every year. And we had 57 in training and 4 training programs. And I thought things were going well and I would go off to Vietnam, so I did. I went back to Indonesia and came upon this man. He's been lying in bed for 3 years. This is not an uncommon story in developing countries. And the reason he was in bed was he had a fractured distal femur. The ends were nowhere near connected, and he was stuck there. And I told my student, why? We talked about this. We had education lectures. And he said, well, he can't afford an implant. And second, even if he could, we get donated implants here from the United States, and we can't use them. We have power surges. And when you have power surges, you can't use power equipment because it's ruined. And so I realized with a sinking heart I'd made a big mistake. I'd wasted 10 years because education, in my opinion, must be combined with the appropriate implants to implement the education. And that was our start. The need is increasing. The traffic accidents kill more people than AIDS, malaria, and TB combined throughout the world. It's aggravated by conflict, and it's, of course, by disaster, where we all shine a light on that area. This is in Bangladesh. The traffic is just of all different kinds. In Vietnam, it's all motorcycles. But these rickshaw drivers have to come out and drive in the traffic. And this was the rickshaw driver that took me back and forth to the hospital when I was in Dhaka. This is where they lived. I could see this from the window. I was staying in a guest house. And their water was groundwater. They had very little sanitation, and they lived tough. And yet, they were spirited young men, and they were very interested in learning. We'd have conversations as I was waiting in the morning. These young men had been sent in from the periphery to earn money for their families. They were sent in because they had no way of making money out in the periphery due to conflict, due to climate. And so they were the supporters of their family. This fella drove up, and I asked him if I could try to drive his rickshaw. And I found it had no gears, and I drive a bike back and forth to work. There was one gear, I should say, just the one. Very poor brakes, and actually I have to say I ran it off the road and it tipped over, which gave me a great respect for him. So this is one side, is the young people sent in to care for their family. The other side, and it's the more common side, is the family, the father or the mother, the wage earner, gets disabled. The family spirals into poverty for 3 generations. That's big. Their way out of poverty is through education, we were talking earlier, and jobs, so they can get better jobs. They want to learn. This is a conference that I was in Afghanistan 3 weeks ago. All of these men came over horrible roads to this conference. They came from Kandahar, Kunduz, where the hospital got bombed, everywhere. They came in, and they're so interested in learning, and it just tore my heart because, and they didn't have anyone to do pelvic fracture surgery in Afghanistan or spinal surgery. These 2 surgeons, that hospital that got bombed in Kunduz, MSF hospital, was a sign hospital. And rather than look for blame, we transferred more instruments and implants to Mazar al-Sharif, where the patients got transferred to. And the MSF surgeon is on your left, and on the right is another surgeon. We'll start a new program in Kunduz to take up the slack. And they came. They were coming along. They heard about Taliban fighting ahead on the road, so they got out of their car and they walked all the way around this fighting area. Somehow found another ride and came to Kabul to the conference. They lay it down for their patients and for their profession. They are wonderful people. I'm really humbled to try to help them. And many people are injured. This man has been 4 months with a fractured tibia in South Sudan. And he has no chance. So we're there in South Sudan. We're doing the orthopedics in Juba. That's the only place they can get treatment in South Sudan. It's a very busy program. And I hope I'm giving you the impression there's a lot of injustice in developing countries. The visit before last in Afghanistan, a car bomb went off. Those things are really loud. And I ran to the hospital, and I saw these men there. They're street cleaners. 9 of them have been killed. It's so unfair that someone they didn't know exploded a car bomb and himself and killed 9 of them. So there's so much injustice in the world. I think it behooves us to try to help. We learn a lot from their injuries. These are blast injuries that occur. They put the sign nail in right away, and we're looking at a different way of treating open fractures now due to their leadership. This was a lesson for me also. These men sat on this concrete wall on the way to the hospital when we first went to Afghanistan. And there was a fight at the front door because they didn't want us to go in. They don't like Americans. And they can stare a hole in you. It's interesting all around the world, the different way people look at you. And it was obvious they didn't like us. And then this little old man fell in a well. And that's what we called him. Their wells don't have protection around us. And he was told by the surgeons, you have to have your feet amputated. He refused, and he was put into another part of the ward and forgotten. The nurses took me to him. I thought we could help him. And so I asked if I could operate on him. They said, well, they wanted to do the other cases they had picked for me to do. And I said, I'm going to operate on this man first, or I'm not doing any more surgery. We operated on him. And when I came out again, those men on the concrete ledge, I caught one of their eyes, and I thought to myself, when two people can look at each other as human beings, that's the beginning of peace. And that was a revelation that we have to emphasize the good people in the world. And there's a lot of good people in the world. They're not just orthopedists there. In Syria, we're in Syria. This is a man. This is our hospital in Aleppo. It got barrel bombed. And one surgeon came. I went over there to teach orthopedics and sign, of course. And he had walked all the way from Damascus. It was right after, it was about 3 months after the first gas attack. And he had treated some of the patients. The gas came off the patient's clothes, and he fainted. He was given atropine, which is the antidote, and he woke up and he was blind for 2 weeks. And then he walked all the way from Damascus to Gaziantep, Turkey, where we were giving the conference. And one of his co-walkers was killed. And I couldn't believe myself that those people give so much for the patients, for their families, for humanity. They're staying in there to work with their patients. And I talked with a lot of the Syrian surgeons during this time. This painting, I saw this in Spain, where I had the idea of a helical nail. This is Napoleon's army. The Spanish had an uprising, and they killed some of Napoleon's soldiers, and so they were executing others. This is a very famous painting by Goya. It's the first of the paintings. It was the origination of Guernica and some of the other very famous paintings against war. Note that this man in the white shirt is much taller than the others. He's on his knees. He's looking at the soldiers. The soldiers aren't even looking at him. And that, to me, describes war. The children don't understand. Disasters. Sign has been to the disaster since the tsunami. We are invited to go there by the surgeons in the country. And I put this picture up because it shows that there's a lot of emotional content to disasters. They're not just an injury. This is a composite. The tsunami is on the lower left. The Pakistan earthquake is on the right. The Pakistan earthquake occurred at 9 o'clock in the morning. A lot of schools fell down, and this is the construction. And those Pakistani surgeons are excellent, as are all the surgeons in that area, India and Pakistan. And in Haiti, the people didn't want to go into the buildings. They're afraid, as they were in Nepal. And so I said, well, we have to take you in to do your surgery, but you can walk. You can go out as soon as you can walk on crutches. And they all walked after the anesthesia wore off. It's a good lesson for immediate mobilization. They went back to staying out there. But things changed in typhoon in the Philippines, where the sign surgeons took care of all of the orthopedic injuries. They organized the evacuation routes. They organized the schedule. And all of the orthopedic injuries were cared for by local sign surgeons. Nepal, same thing. 99% were handled by local surgeons. And we talk about disaster response. I think a major way to do the disaster response is to train the surgeons in the area and give them the implants, and they can handle it. And this has been shown in Nepal. I didn't go back to Nepal until I was asked, and they really invited me back to show how well they had done. Out of this tent here, given by the Canadian Army, no infections. They had one amputation in all in Nepal. So they took good care. We had a conference there, and they looked to see how will we handle the next earthquake. There's 2 areas in the world where they're more common to have earthquakes, according to seismologists, are still in Nepal and in Haiti. So we want to start programs in areas where there's a lot of congestion on the highway and a good hospital and surgeons, and where there's seismic activity. The hospital system can't withstand this. This is an emergency room in Ethiopia. We couldn't even get in between the patients. They're backed up. They're backed up because there's more and more road traffic accidents. And this is how they're backed up. On the wards, they're all waiting for surgery. And the longer they wait, we're doing a study now to see what difference does it make 2 weeks, 4 weeks after injury. And after about 4 weeks, indications are that it takes twice as long because the reduction takes most of the time. So we want to do a study. We want to know how we can help the people and what would be the mechanism. So our mission then is to provide ongoing education, a continuous supply of appropriate implants. In our situation, this means implants that can be used without power. No C-arm or power tools. They have to be donated because the people can't afford them. And we have to validate what we do. We can't just go over there and give implants and hope. We have to get x-rays, not just the post-op x-rays, but follow-up. So we validate what they're doing, and we can continue to improve our help for them. We use our tactile sense. I feel much more secure with the tactile sense in my fingers than I do with visual, because I've been doing this so long. But in tactile sense is procedural memory. It never leaves you. You may forget things, but it's like riding a bicycle. You can come back to riding a bicycle 20 years later and still ride the bicycle. So we designed a nail. It's solid, and a lot of these things I want to be is our luck. We used a solid nail because we could get solid bar stock at the time. But there's less deflection when you put the nail in. There's less infection because the biofilm can't form in the middle of the nail. It's stronger so we can use slots. Our patients heal faster because they dynamize as they walk. We ask everybody to walk the day after surgery with crutches. There's no arc of radius. There's 2 bends, but the femur has a curved canal. But this provides better. Kuncher showed us this because his nail was a straight nail. And if you want to demonstrate it to yourself, we took a piece of PVC and curved it like a femur, made a fracture, and then put a curved nail in, arc of radius, or a straight nail. And a straight nail provides much better fixation, just innately, just with a nail. We had to use reamers that are hand reamers, and there's a lot of hidden benefits to this that have come to fore. It shapes the canal. It doesn't ream the canal all the way around, so the blood supply is left. You can take the bone from these reamers and use it as a bone graft. Our reamers, our smaller reamers are pointed, and our larger reamers are blunt tipped. We use a lot of very sophisticated technology. We use SolidWorks. Materialize, the president of Materialize, a Belgium company, has been very kind to us. He gives us their software free. I met him actually in Iraq, in Jordan, when we were doing facial reconstructions. But it has to be done with sophisticated machines. So we tested all of the, or we evaluated the canals around the world. They're remarkably similar. The big difference is the hardness of the bone. But these are the areas where we designed for. The one on the left is Bangladesh. And you don't see a C-arm there. And we operated by the light of the window. In Vietnam, we used ether anesthesia, which meant you couldn't use a cautery anyway. We've incorporated the system, the surgeon, into our system. And this is very important. So when something goes wrong, the surgeon doesn't blame the nurse or blame someone else. The surgeon is part of the system. And we all take responsibility for each case, failures and successes. If someone forgets to do something or prepare for the case, we all take, and so we all learn from it if we all take responsibility. We're FDA cleared, which is becoming increasingly burdensome with all the increasing compliance, but we feel like it's necessary. So the surgeons around the world know they're getting a world-class implant. We started in the tibia because the tibia has greater consequence. A tibia fracture, which is open, if you have to wait 2 weeks, it has a big chance of infection. So we can do a closed reduction if we can get the fracture within 10 days. This girl came in, and this was in 1999, and she came in, and we knew what to do with the tibia. At that time, very few retrograde nails were being done, and I'll try to not to make this too orthopedic-y. Mark Swinkowski had done retrograde, but he did it from the side, and there actually were a couple papers that we didn't know about. But we said, why don't we just run the nail up through the notch of the femur? So we were right there. We had an incision there to do the tibia. We did this. And this is a picture they sent me. We didn't have internet back then. And so the picture shows her standing on her fractured leg at 6 weeks. And this doesn't mean it's a good operation, but it sure gives us a lot of encouragement. This is then Dr. Quang from Vietnam wrote me, we've done your surgery in antegrade, which is down from the hip down. And at that time, they were developing the Gamma nail, and all the other implant companies were developing nails, which had an enlargement in the proximal end so they could get a big compression screw up through into the femoral head. Well, I said, oh, we're going to have to redesign. And Dr. Quang told me, now this is not me, this is him. He said, no, you don't have to do that. He said, keep your design the way it is and allow it to, as it's going in, when you get to the bend in the top of the nail, as it will bend as it will rotate as it will. And I've learned since and studied the femur that there's a helix there. And it just goes down the helix. It doesn't try to reshape the proximal femur. And this has worked out very well. This is Dr. Quang's idea. All of these ideas are cumulative. This is in India. In India, it's very important to have a good base to eat with your hands. This man had had 6 operations. So in Mumbai, they used the sign nail. And he's able to work, able to use his hand. And if you look at that, look how far that nail goes down, and then look at his flexion. So we're studying that. So there's something about the distal humerus that if you can straighten it out, you can treat these more with nails. And we're studying this, and we find that it works very well. Our surgeons are doing this. Back to Afghanistan, I'm a little still thinking about Afghanistan because of the recent trip, but this is a man in traction with a broken hip. They treat their hips there with traction for 3 weeks and then a body cast. And it was so cold there, everyone gets electricity 6 hours a day, but you don't know which 6 hours. So I could imagine this was cruel. So we decided to make a hip system. We wanted to treat all fractured hips, not just stable, not just unstable. Dr. Chapman did some early work a long time ago where he compared the DHS and basilar neck fractures, as you can see in the top right there, to the DHS to 3 compression screws. And we learned a lot from that. So we have made our system modular so we can address all of the different reasons to treat hip fractures. We did bench testing for 3 years. And we chose the most unstable fracture. We took a big piece out of the posterior medial fragment, made a fracture through the trochanter, and that's also a transverse fracture. And what we came up with was a compression screw, and we could put our finger through there because we don't have a C-arm. You can feel the fracture site. The assistant pulls on it and rotates. Once it's closed, put the compression screw in. It really holds it quite well. And I've just seen a review. David Shear, who was here, a resident and a fellow of Dr. Chapman's, has worked on this. And this is working out very well. If you don't have a C-arm and you take a DHS and put it in and you don't get it just right, it's taken out a lot of the bone in that femoral neck and femoral head. So we went back to Afghanistan and used it. This is the patient walking on that hip. It's important that we validate. Our database now is probably the largest in the world, and so we're beginning not just to see what sign does, but to learn principles of fracture treatment. And we're developing these more and more, and they're being published in the Journal of Orthopedic Trauma and other areas. Another slow hunch. This is back again to the idea of a sentinel event. I was in Bangladesh, and I hung up a reamer. In other words, I got the reamer in, I couldn't get it in, couldn't get it out. We wanted to do one more case before we left, and it was very frustrating. It was frustrating also because the people we were used to the people in Vietnam where the bones were soft. We went to Bangladesh, the bones were hard, and the hand drill we used kept skiving off the bone, and it was very frustrating. So I came home and I ride a bicycle, and all of a sudden occurred, what about putting the flutes of the reamer, which stuck in the canal, on the end of our nail? Then we wouldn't have to do a distal interlock, and it would be a much quicker case. Well, this idea was the beginning of our fin nail. And this fin nail has just been reviewed by surgeons from Boston and Canada and found to be as stable as a standard nail. See, they've reviewed both. They have some computerized way of doing this. And so this gave us great encouragement to pursue and to use the fin nail more. And we use it for now unstable fractures, and it works very well. This is our squat and smile picture. This is a very important picture to us because we feel that this shows bony healing much better than x-rays. If a patient can squat and smile, very rarely do they go on to a non-union. The fin nail works by 3-point fixation. It drives the fin into the canal. That's how it works. And now it's on our pediatric nail. This nail was, you might say, was much too distal to use, and we're working on a way to go through the distal femoral epiphysis. We're working on sheep. A 4-month-old sheep is equivalent to an adolescent. So at Case Western Reserve, they're doing this research. And we started off in Ethiopia. I saw these sheep going down the road to market, and I thought I could save a few of them from the market. And it worked. And I think it'll revolutionize. So education, and that's one of your strong points. We have the group education, conferences. We have individual. If the conference is small enough, small groups, you can talk back and forth about different ways of doing things. And I feel like these are very effective. And And then we have the hands-on. These are very important too. This is in Afghanistan. So there's many ways to teach, and I noticed that you have a cadaver lab here, and you have a hands-on lab, and you have digital, and so you're getting all these different ways of teaching, and I hope we can collaborate on that, because it's hard to do it all one-to-one or group-to-group. If it could be electronic, it would be much better. With the surgeons, we have active participation, as I mentioned, and we're all over the world, and we've got to communicate more. We're in 52 countries, and we've got to come in digitally and do this, but not neglect the surgery, not neglect the cadaver, hands-on. So there's got to be a combination way to teach. We just started 5 new programs to try to reach more people. So the fruits of the education are many. I mean, when you teach a resident something, that resident goes off and uses that knowledge a lot. We have a surgeon network around the world, and this was brought home to me. Our first sign flap course, we want to teach soft tissue also, was at Duke. And Scott Levin at that time was the chief, and I chose these men. Some of these were residents, and some of these were out in practice. And Dr. Bhaskar Pan, standing next to Dr. Levin there, was a resident in the Philippines. He's from the Nepal. And Dr. Levin is known as an expert now in hand replantation. Well, Bhaskar, when he heard that, pipes up and said, I've done 3. So, I mean, these guys are doing good surgery around the world. I think they're better than we are. This is where we teach the Ponseti also. In Afghanistan, a surgeon came to the sign conference, and he learned how to do Ponseti. His son was born with club feet, and this is a result of his Ponseti treatment. So we have 95,000 surgical reports, though we've done 155,000. We didn't start the database until 2003. So now we can evaluate fracture principles and learn more. We have a global network of surgeons throughout the world who are very interested in working together and improving care. They're very innovative surgeons, so we're just a big group goal there. I want to talk about a little bit of our legacy and use this patient as an example. She has a benign tumor. It's a ossifying non-ossifying fibroma. She had a very antalgic gait, and so we thought about how can we correct her deformity. You can see a 90-degree varus. You can see, you can't see the procurvatum of her. But the point is she had a deformity and she had a tumor. So we started thinking about it. We started talking about it. And we drew out different ways that we could do it, different osteotomies that we could use. And they presented the patient the first day I was there, and we were going to operate on the last day. So we had a chance to think it over. And so we all got together and started thinking different ways. And all of a sudden, I said, we've got to see the patient. One thing they did was used modeling clay to work on the deformity, and it works very well. It's a Play-Doh type thing. Then we went back to see the child, and she is so shy and self-conscious. She could hardly walk without pain. Her father looked at me and said, "This is our only child." And so what we do, we can look at x-rays and we can look at other things, but there's always a patient behind that and a family behind that, and that's why it's so important to do the right thing. So we operated on the child. The resident did the surgery. We always try to stand behind the residents. The surgery came out very well. We've got 127 degrees angle of the shaft. And this is our new plate, which is used for subtrochanteric fractures and hip fractures. And it's holding her. There she is standing about 3 days after surgery, completely changed young lady. So the legacy that we try to leave is not just X-rays and biomechanics and stuff. It's concern for the patient, patient care, emphasizing the good people in the world. And it's a network of surgeons. It's also a network of patients. And we all establish problems that we need to solve. We need to solve the problem of open fractures. And so we're looking at different ways to do this. We can make a negative pressure wound therapy out of an aquarium pump and just reverse the flow. And we're looking at innovations that we can do for that. We all have a patch to hoe. Tolkien says this. I strongly believe that all of us in our lives, we may have that patch to hoe in ourselves, or our family, or our neighbor, or somewhere, but we all have a condition in the world that we want to change. We want to help. The hoe is the symbol of the knowledge that we learn and the way we try to do this. And we're all working in different ways and different aspects of this, and we hope we can collaborate so we get more emphasis from both of us, more potential. A lot of good things have come out of our patch. 155,000 patients. Surgeons have been innovative, and it gives them the tools they want to work. But you notice that discolored area around the patch. And this is the part I'm not happy with, because these are the patients that we're not treating. We're not treating spinal injuries well. We're not treating pelvic fracture injuries well. We need to do more of what we do well with femurs and tibias and humerus and hips. And so we need to look for a new pattern, a way to do things, a new platform. We need to take advantage of digital communication and other ways, as well as keep our sense of innovation. And I think if we work all this together, we can help many, many more people. We were very happy that Dr. Chapman and Dr. Patel came to talk with us. It was an outstanding presentation. It showed me the value of using digital and the value of using models, because they gave a very excellent presentation and brought up the fact we have to consider the head injury too, even though we may not treat it. We have to consider the whole patient. So the collaboration, which I hope we can work on, is education, digital ways, that's changing rapidly as we go, treatment of different injuries, different ways to educate, which will lead to appropriate implants around the world, and ones that they can use and have available and are economical. I like to ascribe to Michelangelo's prayer of, Lord, grant that I may always desire more than I can accomplish. And we have to keep our goal way ahead. We have to keep thinking ahead and try to do things that people say you can't do. We can do them. So right now, the sign nail is the red. We're working on intra-articular fractures, and we hope to expand now into pelvic fracture and spinal injuries. These are not taken care of well in developing countries, and they cause a lot of disability. And the surgeons there are very interested in working. We can always dream. The ultimate dream for me is a trauma center in a developing country where it would be integrated with the surrounding hospitals. The patient would come into those hospitals, be sent to this center, have the surgery on a timely basis, not wait for 4 weeks, and be sent back to the hospital. The surgeons there would be the leaders in teaching orthopedics and teaching different procedures. And so it would gather together a lot of good ideas. Providence Hospital has an outreach overseas, so they could learn hospital administration and nursing and all the other aspects that are necessary for this. And this is a dream that I hope we can do in developing countries. We're working toward it. People have said you can't do it. We've got one being built now in the Philippines, and several planned. One's planned also in Kenya. So we need to contemplate these things. And another value of going on a trip is a chance to change your point of view. You don't many times go over to change things, you go over to change yourself. And this is the Gobi Desert. I worked in Ulaanbaatar and then went out the Gobi Desert to completely different and thought of a lot of things and how we can work better orthopedics around the world. It's not easy. There's a lot of agony involved. There's agony involved when you see patients that are disabled and don't need to be. There's a lot of ecstasy involved when you see a patient who had no chance, but now is walking and happy and smiling. That's why we call it the squat and smile, because many of these patients have very vibrant smiles. I want to close with two pictures. This is, these women are Maasai women. I like to travel to Arusha whenever I can. There's a hospital there with one surgeon, one staff, and they all work together. We see patients in between the surgery. They all work together. It's a very congenial group. And we work for 12 hours a day. We do 6 cases a day. 6 cases at least a day, one operating room. And we have just a wonderful time. And he goes around when he knows we're going to come there and picks out difficult surgeries. These 3 Maasai women had fractured femurs, and he found them. They had to crawl everywhere they were. They had their fractured femurs for 5 years, 4 years, and 3.5 years. I mean, they were really osteoporotic. And so we operated on them, and you can see the result. And this is the ecstasy of seeing patients who didn't have a chance before that you can help. And of course, the children have a long life to live, and we treat a lot of children. We're treating more and more with our pediatric femoral nail and our other pediatric implants, and they are very grateful and happy too. So that's all. Thank you very much.